Complications of thyroidectomy. There are at least 7 complications are there in thyroidectomy. These on the left side, these are all very most important complications of the thyroidectomy. That is what I have given in the green box, and these are the major complications. Whereas on the right side, that is a minor complication, and that orange color what you are seeing, that no, that is a minor complication. Okay, we will discuss one by one. That is, we will start with first. We will start with hemorrhage. Okay, so hemorrhage is one of the important complication in thyroidectomy, particularly, and this is the most common complication. First of all, this is most common complication, and it is one of the important life threatening complication. Okay, so life threatening complication. Then most important thing, the hemorrhage you will get, typically you will get a hemorrhage called reactionary hemorrhage. So what do you mean by reactionary hemorrhage? Reactionary hemorrhage means that you are getting, after surgery, within 24 hours you are getting bleeding. You can call it as reactionary hemorrhage. Okay, then what is the commonest cause for the reactionary hemorrhage? That is due to the slippage of the superior thyroid pedicle. Slippage of the superior thyroid pedicle. Okay, so this is the hemorrhage. And once there is a hemorrhage is there, it forms an important thing, that is it forms a hematoma, that is called tension hematoma. Okay, so for that you should know the basic anatomy. Okay, consider this is a cross section, and first layer, that is skin. Okay, and then second layer is there. Second layer, it is an subcutaneous tissue. Okay, this is subcutaneous space is there. Then third one is the investing layer of deep cervical fascia. You got an investing layer of deep cervical fascia, and below that you will be having the muscle. Strap muscle will be there, and below that you will be having the thyroid gland. Okay, so this is a location for thyroid gland. Just imagine that if you got any bleeding in this location, okay, so it will be enclosed in this layer. So this hemorrhage will be, it will happen, but it cannot pass beyond the deep cervical fascia. So it will be enclosed and it cannot expand beyond that plane. And what is the most important and immediate posterior structure of thyroid gland is a structure, trachea. So immediately what will happen? This trachea will go for obstruction, and that patient, and this condition, what you can call it as tension hematoma, and ultimately it produces the compression over the trachea, which leads to respiratory obstruction. That is, the patient will present with stridor. Okay, so patient not able to breathe, and they will be presenting with stridor. Okay, how to prevent or how to avoid the tension hematoma? So what are the things you have to follow? Okay, first one, that is the ligature of the superior thyroid pedicle. This ligature you have to do it very carefully, and you see to that you have put a ligature properly. Okay, so that is the first thing, how to avoid the tension hematoma. Okay, first one is the ligature. Ligature, it has to be very safe ligature. Okay, and usually what will you do? You will put two ligature on the proximal aspect, that is one ligature on the towards the specimen side. Okay, for the safety purpose you are putting two ligature on the proximal aspect. Okay, then this is a safe ligature. And number two, after the surgery, when you are closing that, approximating the strap muscles, you are just splitting in the midline. When you are going to oppose these strap muscles, avoid watertight closure of the strap muscles. Okay, watertight closure of the strap muscles. Instead of that, just to put loose stitches. Okay, suppose if you put loose stitches, what will happen? If there is any hematoma or any bleeding is there, Okay, this bleeding will come through this opening, and it will present in extend into the subcutaneous plane, so that the tension can be avoided. Okay, this is the next thing you have to follow. And third thing, you should keep the patient under close observation. Okay, over a period for at least 24 hours, keep a close observation. So that is the next thing you can do. Okay, these things are you can prevent, how to prevent the tension hematoma. Okay, once hematoma is formed, okay, then what will you do? The first step, immediately what you have to do is, you have to do immediately, you try to let out the sutures and relieve the tension. Okay, so try to let out the sutures, and evacuation of the clot, try to evacuate the blood clot, so that the tension will be relieved and patient will be relieved of the respiratory obstruction. Then under control, that is under endotracheal general anesthesia, you take the patient to OT, and try to find out what is the cause for bleeding, and try to arrest the bleeding. So that is the thing you have to do in case of tension hematoma. Okay, this is the first complication. The second complication is recurrent laryngeal nerve palsy, and as well as the superior laryngeal nerve palsy. Okay, so this palsy, recurrent laryngeal nerve palsy, either you will be having unilateral, that is on single side you can get, or you can get bilateral. Okay, or sometimes you can get either it is a temporary one or it is a permanent one. Okay, so these are types of the palsy you will get. Unilateral, what will happen if the recurrent laryngeal nerve is injured? You will get a complaint, the patient post-operatively will complain of hoarseness of voice. So that is a complaint the patient will tell you. Bilaterally, what will happen? Bilaterally, what will happen? The patient definitely, most of the time, it will produce with the respiratory obstruction or respiratory distress will be there. Patient will be presenting with stridor. Okay, so this will be the presentation. Okay, for unilateral, what will you do? So nothing can be done if it is a temporary and transient. Just give speech therapy if at all, and if you want, you can add some steroids for some days. So most of the time, if it is temporary, over 3 months period, it will resolve by itself. You can diagnose post-operatively by laryngoscope. You put a laryngoscope and you can diagnose whether it is a unilateral or bilateral. Okay, bilateral, what will you do? Some bilateral, definitely what you have to do, a procedure called immediately, you have to do the tracheostomy. Okay, to relieve the obstruction, you have to do the tracheostomy. Okay, so under definitive procedures, that is called medialization of the cord. Okay, so the cords, vocal cords, if it is present in a completely adducted position, you can do the medialization procedures. Okay, medialization. And this one, you can get, sometimes you will get cadaveric in position, you don't get much symptoms, mild distress only will be there. Okay, so this procedures, you can, medialization procedures can be done to relieve the vocal cord palsy. So something it will work. And what will you do for this? What will happen when there is a superior laryngeal nerve palsy? Superior laryngeal nerve palsy, that is particularly the external branch. Okay, it will be injured when you are ligating the superior thyroid pedicle. This SLN palsy, so you can, the most of the time they will be presenting with a simple symptom, that is a loss of timbre of voice. Loss of timbre of voice, that will be the presentation if it is in the superior laryngeal nerve palsy. Okay, so recurrent laryngeal nerve, or this nerve, if it is injured, intraoperatively you are diagnosing. First thing you can do, a re-anastomosis. That is a end-to-end anastomosis can be done. So anastomosis can be done. That is a primary anastomosis. You can, okay, you can see the cut and you can anastomose directly. Some cases, what will happen? Recurrent laryngeal nerve is there. It is passing through the tumor. While resecting the tumor, some part of the nerve also you are going to take out that. Then you will be having some amount of nerve you will be losing. So in that cases, what you have to do? You have to do anastomosis with ansa cervicalis. Okay, ansa cervicalis, you can do the anastomosis. Okay, so this thing can be done, and sometimes you can use the nerve graft also. You can use the nerve graft to replace this injury. Okay, and the next complication is hypoparathyroidism. So what is over the hypopara? Because hypoparathyroid glands are commonly four glands are there, two superior and two inferior. So these glands commonly come across. It may be there are two causes why you are getting hypoparathyroidism in thyroidectomy. Number one, the common cause is vascular injury. Okay, the blood supply to the inferior parathyroid gland or superior parathyroid gland. So vascular injury is there, then there definitely you will get an injury, and or else some accidentally you may remove the parathyroid gland. Accidentally you may remove the parathyroid gland. In that case also you will get hypoparathyroidism. Okay, so what will you do? Suppose if you removed accidentally you remove the parathyroid gland, what you have to do? You can do one thing. You can implant this parathyroid gland into the sternocleidomastoid muscle, or in the forearm of the opposite side. You can forearm muscle. You can implant this parathyroid gland. So this is one way you can correct the hypoparathyroidism, or else what will be the clinical manifestation? So this hypoparathyroidism commonly it will cause us a condition called hypocalcemia, or you can otherwise call it as tetany. So what do you mean by tetany? What are the clinical manifestations of tetany? So clinically the patient will be complaining of numbness. Numbness will be there, and as well as tingling sensation. Okay, as well as tingling sensation, particularly in the extremities as well as in the perioral region. So this complaint, the presentation, hypoparathyroidism, usually it will present 2 to 5 days after the surgery. That is, you can expect on the third or third post-operative day. Okay, 2 to 5 days. So why? Because some drive will be there. So some drive will be there. After that only it will manifest. So it is not an immediately you don't get this hyperparathyroidism. So in the 2 to 5 days immediate post-operative day you can get. Okay, then other manifestation, there are some sign called Chaustuck sign. Chaustuck sign, nothing but tapping over the facial nerve. Okay, if you are tapping over the facial nerve, there will be numbness and tingling sensation be there. That is called Chaustuck sign. Then another sign, it is called Trousius sign. Trousius sign, otherwise called, it is called obstetrician hand. Okay, what will happen? The patient will be presenting in this position. Okay, that is the flexion at the metacarpophalangeal joint and extension of the all interphalangeal joint and the thumb in adduction. So this position is called as obstetrician hand. Okay, this is Trousius sign, otherwise called, or sometimes there is otherwise you can call it as carpopedal spasm. Okay, some cases, what will you do? Some cases, if you when you are measuring the BP, if the systolic blood pressure above that you are keeping for 5 to 10 minutes, the patient will develop this carpopedal spasm. So that is also one of the clinical manifestations of hypocalcemia. Okay, so how will you treat this tetany or hypocalcemia immediately? So you can treat with calcium-based drugs. Okay, so you can treat with calcium-based drugs like, so you can injection, that is a calcium gluconate, injection calcium gluconate. Okay, calcium gluconate, 10 percentage. Okay, 10 percentage of calcium gluconate. You have to give slow IV infusion over 10 minutes. This is to avoid the arrhythmias. Okay, arrhythmias. That's why you have to give very slowly. So this is one drug, and oral drug. Okay, oral drug, that is tablet calcium. Okay, tablet calcium, that is 500 milligram oral OD. Okay, you can give it for at least for 3 months or lifelong if it is necessary. Okay, these two are the treatment modality for the hypocalcemia or hypoparathyroidism. Next one is hypothyroidism. Okay, it's particularly it will manifest when the patient is having when the patient you are doing total thyroidectomy. So what will happen? Hypothyroidism. So you don't have any thyroid tissue. In that cases, it has to be replaced. That is particularly you will replace with thyroxine. Okay, thyroxine you have to replace. So the dose all depends upon the what type of surgery you are going to give. Okay, so you are going to do. So you will do a replacement, or you can do the supplemental, or you can give the supportive. So whatever the modality based on the types of thyroidectomy, based on that you will do the give this treatment. You know the manifestations of hypothyroidism, and this is the basic drug you have to treat, and it has to continue for it is a permanent one, you have to continue for lifelong. Okay, so these are the major complications. So if we come to the minor complication, the first one is the wound infection. So wound infection, commonly the patient will be presenting either presenting with cellulitis. Okay, cellulitis you can treat with an antibiotics. Okay, so it will resolve by itself. Sometimes it will be presenting with an deep seat abscess. So in that case you have to plan for the incision and drainage. Okay, and the next one is the hypertrophic scar or keloid. So what will happen in that case, what you have to do, so you have to treat either with a steroid, intralesional steroid injection. Okay, or else you can plan for the excision of the this hypertrophic scar or keloid. That is a treatment for these conditions. Stitch granuloma, so sometimes we will use this material called non-absorbable material, that is silk suture. So that causes a stitch granuloma. So once it is developed, then you can plan for the excision of the stitch granuloma. Okay, so these are all the complications of the thyroidectomy.